well, if you want to leave clinical medicine, do locums first, because a lot of W-2 jobs have a lot of negativity that has nothing to do with your patient-doctor relationship. It's all the other stuff in the bureaucracy and meetings and administrators and stuff that you don't have to deal with in locum. So I say before you quit and go run a restaurant, or start that other career, do locums for a while. And I've had many, many doctors who tell me, Dr. Wilner, I was burnt out and I did locums. I love medicine. Now that I'm only doing it, 8 months a year, this is the most wonderful thing in the world. So sometimes it's not that you don't like being a doctor, it's that you don't like the system.
Welcome to Be Empowered, the podcast. This is a podcast where we dive into the realities of healthcare and entrepreneurship. We offer our opinion, unfiltered and unapologetic, and always with a dose of empowerment. We're here to amplify voices, both yours and ours, challenge the status quo, and explore what it truly means to thrive. So let's get into it. I'm Dr. Santoshi Bilakota.
And I'm Dr. Shalom Mokbel.
And today we have a very special guest. We have Dr. Andrew Wilner. He's a board-certified internist, a neurologist, and an epilepsy specialist. In 1982, he discovered that locum tenens was a perfect solution to achieve work-life balance. And since then, he's practiced locum tenens in a variety of settings, inpatient, outpatient, academic, and community. He's currently an associate professor of neurology at the University of Tennessee Health Science Center in Memphis. He's also the author of the Locum Life, A Physician's Guide to Locum Tenens, and host and producer and editor of Art of Medicine podcast by Dr. Wilner. A lot of accomplishments, Dr. Wilner. Thank you so much for joining us. Did I miss anything? Or would you like to add anything more about yourself for the audience?
Well, my resume is over 100 pages long, so we won't include all of those things. I think you hit the one thing I could mention is I have a YouTube channel called Underwater with Dr. Andrew, which has curated videos. They're narrated kind of natural history things of underwater creatures, which is one of my passions. And they're all short, 3 minutes, 4 minutes, a couple of award-winning videos there. Mostly from Southeast Asia, Philippines, and Indonesia. So if you're looking for something really a big step away from medicine, just to relax, or if you have kids and you want to watch some underwater creatures, that's for fun. Otherwise, you got it all right. Thank you very much, and it's a real pleasure to be here.
That's amazing. So would you say that's a hobby of yours, and you can manage it because of doing locum tenens?
Well, great seg into locum tenens, yes, because I had a very traditional training, medical school, internship, residency, but my model was the internal medicine doctors. In those days, those were the doctors that knew everything. My dad's friends, the doctors we went to. In fact, my dad's best friend became the dean of Brown Medical School, and he was a practitioner. But so it was a different time, and so my model was I'm going to be an internist. So I did an internship in internal medicine, and it was very demanding. My first day off was Christmas Day, started on July 1. We rounded 7 days a week, saw patients, and it was by month. So 1 month in the ICU, 1 month in cardiology, 1 month in renal, 1 month in GI. On the first day, you don't know anything. And by the end of the month, you could handle most of the problems in a reasonable way. And it was all very interesting to me, but none of it really stood out. Also, I have a passion ever since I could write, really, that I was a writer and I wanted to write. And I had a book that I wanted to write. And of course, I made a deal with myself. I said, when you do your internship, no writing. Just focus on your main goal here, which is to survive your internship and do a great job. So I did that. But I started getting itchy. So I talked to my program director and I said, I want to take a gap year. Gap years weren't a thing then. And it was kind of revolutionary. And I said, I want to write a book. And he said, okay, come back, the year after, we don't care. So but I needed to support myself. So a bunch of the residents were moonlighting at this little ER, Bellwood General Hospital, which had 2 beds and 1 nurse. And they would moonlight there to make extra money. So I talked to them and talked to the hospital, and they hired me. So I worked there 3 shifts a week, 12-hour shifts. So it was 36 hours. That was like part-time, right? If I'd been working 7 days a week. So now I had 3 days at the hospital and 4 days to write. And it was during that time that I discovered neurology. The patients that came in that were dizzy or stumbling around, or their eyes were crossed, or they were numb on one side of the face. It's like, this is pretty interesting. So it actually helped me locum tenens. We'll call that a locum tenens year. Figure out what I was going to do with my life ultimately. And it gave me time to write the book. And going forward, I found that balancing my passion for writing and maybe a little bit for adventure, that the full-time job just didn't work well for me. And although I was very reluctant to give it up, I worked for 8 years in a traditional neurology practice. I had partners. I rounded at the hospital. I had a clinic. Eventually, it got a little boring, and I wanted an academic position, and I found one. And it turned at an Ivy League school, and it turned out to be terrible. And so I quit. And then I didn't know what to do. So it's like, okay, I had moved for this new academic position, and it was terrible. So all of a sudden I was a free agent. So I started working as a medical journalist. And because I had gone to a lot of meetings, in the meetings, you got a poster and some guy walks up to you and says, "Hey, I'm writing for Neurology Times or Neurology Reviews or Neurology something, tell me what your poster is about." And I had that experience when I had presented posters, and I thought, gee, I can do that. So I called some of the magazines and said, how about if I give that a shot? And they said, sure. So I worked for 10 years as a medical journalist and not seeing patients anymore. And then when I got back, I started Locum Tenens because I really didn't want this full-time commitment, and I wanted to travel. And then Southeast Asia sort of appeared on my horizon, and I started spending 6 months there and then 6 months back in the US working, so I'd have enough money to spend another 6 months back in Southeast Asia. And I did that for about 10 years. And I was single at the time, so all I had to do was negotiate with this one. Didn't have to get anybody else's permission. And I had bought a very small, inexpensive condo, which was my base of operation. So I didn't have a big mortgage and those days I had paid off my student loans. So I was, pretty good shape to be flexible. And the locums just seemed natural to me. And it wasn't a thing. It was just a way to sort of do what I wanted to do.
I think what you said about starting a W-2 practice or joining a private practice rather, or being a W-2 employee at an academic center, and then it turns out that you don't necessarily like it. I've had that experience, and I'm sure others who are listening might have as well. How did you end up finding contracts to kind of pivot yourself out of that? Because I think, as we discussed offline right now, it's a lot more popular, and it's becoming more popular as people are realizing that it affords a better work-life balance. But I'm assuming back then it was a little harder to find contracts. Was that just through connections, through conferences, or how did you achieve that?
Well, if you want the real story, so after my 10 years of working full-time as a medical journalist, during which time I actually started doing some medical mission work, and of course I kept up my licenses and my CME credits, and I went to about 8 conferences a year where I would work furiously to interview as many people as I could and rush back to my hotel room, stay up to midnight typing to send these stories in so that I could make a living. And eventually I thought, I'm getting a little rusty on what's new, because what was new when I left 10 years before were, for example, some of the new epilepsy drugs. I'm an epileptologist. I had worked on topiramate and lamotrigine, before they were introduced. Well, now they were, just regular stuff. And there was new stuff coming down the pike that I didn't know anything about. I thought I ought to get back into clinical medicine. And then I found out that I couldn't. because all of the hospitals require you to submit recommendations from a peer who has seen you work in the last 2 years. So I even had a job lined up. I went to Orlando. There was this new thing, neurohospitalist. And I liked Orlando. They had a busy hospital. They really needed somebody. And I liked Orlando. It looked like a nice place to live. And basically all said, I went home after the interview, waiting for the contract. And some guy called me and he said, well, we need some letters of reference. And I said, that's problematic because I actually haven't worked in the last 2 years. So it's kind of a catch-22. I said, I have people who could vouch for me as a medical mission worker. They said, oh, volunteer work doesn't count. It has to be employment. And I said, well, without lying to you, there's just no way I can produce what you're asking for. And they said, oh, okay, thank you. And then I never heard from them again. So it was like, gee, now what? So I approached several other kind of places and even locum tenens companies, and I got the same story. And then finally, I don't know, I was doing speaking and other stuff. I was on my way actually to your hometown there, New York City, to do a video like this in a studio. And I got a call from New London that they had 6 neurologists and all but one had left for a variety of reasons. And so to talk a little bit about locum tenens, that's a little bit of a red flag, right? When they really, really need you, that's because the people who were there have left. And there's a reason for that. So you got to be prepared for that. And they said and some was innocent. Oh, one lady left to be with her husband who got a better job, and another lady was pregnant and decided to do something different. But it was still a little suspicious. But they said, we really want you to come. We understand you're looking for a position. And I said, well, I'm not going to bother. I said, because you're going to do the same story with me. And then at the end, you're going to say, you can't hire me. And I was in my early 50s at that time, and I had not been practicing as a physician. I wondered, well, maybe it's just time to, hang up the gun. And that's it, hang up the stethoscope. So it was a difficult time. Anyway, I decided to stop there. The train, if you're familiar with the geography, I was in Newport, Rhode Island, and the train goes right through New London on the way to New York. So I said, I'll tell you what, on my way back from New York, I'll stop and I'll chat with you. And so I did. And then we had that discussion where they can't hire me. And it's like, well, okay. And they said, well, isn't there somebody who could maybe write you a letter? Or couldn't you go spend 2 weeks somewhere and get somebody to write you a letter, and then we'll put you on probation and we'll hire you? So I had an old epilepsy buddy who you may know, Salim Benbadis. You know Salim? He's a great guy. And we had been on speakers bureaus together, and he's in charge of the epilepsy monitoring unit in Tampa. I think he still is. So I called Salim. I told him the story. I said, what do you think? Yeah, he said, sure, come on down. So on my own dime, I flew down to Florida, rented a hotel room for 2 weeks, and I was the oldest medical student on the team, and so I was trying to impress the attending without showing him up. It was a very delicate balance there. And anyway, I did my 2 weeks. Salim said, here, write yourself a letter, I'll sign it. So I wrote a letter. Dr. Wilner showed up. He was good with the patient, seemed to know what he was doing. And then they hired me in New London, and I worked there for a year, and I kept my medical journalism going. So it was an incredibly intense year because I worked every other week. That was the new thing, neurohospitalist. As a clinician, 24/7 for a week. Mondays, I would do my laundry and go food shopping. And then Tuesdays through Sunday, I would either go somewhere for a meeting or just write, and then pick it all up again. So it was a very intense year. I want to stop for a second just to emphasize that if you have this burnout, or I want to do something different, that's great that you're introspective enough and insightful enough to realize it. But you cannot leave clinical practice for more than 2 years, and preferably more than 1 year, without possibly slamming the door behind you because of these rules and regulations. I was very, very lucky that I found a workaround. But there are stories that I've heard of women, for example, they take three years off because they just had a baby. They want to be with their baby. And then they want to go back working as an OBGYN or dermatologist, whatever it is. And they can't. They cannot get hospital privileges. Now, if you have your own clinic, you can do pretty much whatever you want. But as soon as the hospital gets involved, it's an enormous JCAH bureaucracy, and they will not bend the rules for you. So think very, very carefully before, when you want to sort of hike around the world, you got to do it in 12 months or less. And one of the ways that locums comes in is that if you do a week of locums here and a week of locums there, it resets the clock. So then you're good. And you can just be nice during that week, so somebody will write you a letter. And that way you don't burn the bridge behind you of clinical medicine. Because I recommend to people, if you want to leave clinical medicine, do locums first. Because a lot of W-2 jobs have a lot of negativity that has nothing to do with your patient-doctor relationship. It's all the other stuff in the bureaucracy and meetings and administrators and stuff that you don't have to deal with in locum. So I say before you quit and go run a restaurant, or start that other career, do locums for a while. And I've had many, many doctors who tell me, Dr. Wilner, I was burnt out and I did locums. I love medicine. Now that I'm only doing it, 8 months a year, this is the most wonderful thing in the world. So sometimes it's not that you don't like being a doctor, it's that you don't like the system. So don't take too much time off. Okay. So pick up the story. So I did the year. I was getting a little burned out, and I decided that I really didn't like giving up my medical journalism career, that was fun. And I like taking care of patients too, but I certainly couldn't do both at the same time. This was not sustainable. My income that year was actually pretty good because I had 2 jobs, but I was like, that's enough. I didn't have time to, play, barely to do the laundry. So that's when locums became so appealing. It's like, okay. In fact, I went back as a locums doctor a few times to that New London hospital because I knew the place. They knew me. It was very easy. But I said, I can't be doing every other week. That just doesn't work for me. So that's when I started doing locums and traveling to Southeast Asia. And it is very liberating. I always wondered, I don't know if you're a doctor, I had this experience, where you might have a sick day or you've got your own doctor's appointment and you leave the hospital at 2:00, right? And there are all these people roaming around. It's like, what are they doing? How come they're not working? You drive by the beach, there are people on the beach. How come they're not working? I used to work, 8, 10, 12 hours a day, and there are all these people roaming around. It's like, what do you do? So when you're really in a tight kind of confined system. And then if you start working locums, you have time, you meet other people like yourself. You meet a lot of entrepreneurs who are working, but they're not in a, sitting in a cubicle 9 to 5 or a dentist office. I mean, imagine being a dentist, right? You're a dentist. What do? You go to your dentist's office and you're in that one room, with the patients, or maybe have 2 rooms, you go back and forth, and that's what you do all day long. And you're not out shopping. You're not out seeing the sights. You're not interacting except right there. It's a very confined existence. And I think doctors who were brought up that way, right? I mean, I spent a lot of time in the Sterling Library at Yale, I mean, if you weren't in class, you were in the library. Or maybe the cafeteria, but I mean, you have your sort of little zones. But as soon as you're in the locums world, it's like, whoa, there's a whole world out there. So very, very different.
So isn't that crazy that after 12 or 13 years, you still have get recommendation letters and go back, as a kind of a medical student? It tells you about the bureaucracy out there. But that's great. So you started the Locum Life a little bit later. It seems like you were in your 50s. So you have experience in both lives. And you touched up on some of the benefits. So can you elaborate more in terms of patient care, autonomy, and burnout? What's the difference between your traditional academic job, private practice, and in comparison to locum jobs?
Well, there's pluses and minuses, and I did a video in my book. I think it's chapter 4, the downside of locums, and it's the most viewed video of all my videos. Thousands and thousands of viewers have watched that one. Whereas the upside, everybody knows. So, and I'll just mention right now, I am traditionally employed, the W-2, by the University of Tennessee, and also by a practice group. So I see patients every day, and I teach at the University of Tennessee. I'm an associate professor. So I actually now have a more traditional job, but my trajectory is not very traditional. But when I see a patient as a locums physician, it's exactly the same as when I see any other patient. People, well, what about continuity of care? I mean, continuity of care is pretty much a fiction in a lot of scenarios. First of all, patients move all the time. Even if they don't move, their insurance changes, which switches which doctor they can go see. Doctors now move much more than they used to, even traditionally employed W-2 doctors. I mean, in the old model that I grew up with, a doctor would hang up a shingle, right? Hopefully buy that office and stay there for his whole life and build a practice, build his reputation within that community so that other doctors would refer to him. And then patients would, oh yeah, that Dr. Wilner, I've heard he's great. But what happened, the system has changed. So now people come to you. I remember when I was in private practice after my fellowship and things started to become more corporate, whenever I got a referral, it's like, oh, wow, who sent you to me? I got to thank him. And I wanted to know. And I say, oh, well, nobody really, my insurance changed. You mean, so you're doing fine. You just need a new doctor because your insurance, and then, had a physical chart like 6 inches thick. So I basically had to reinvent the wheel and review everything and examine them to make sure that the other guy had actually done what he was supposed to do, which they usually had, all because their insurance changed. I mean, it was just a cycling of someone who was completely unnecessary. And it wasn't very flattering either, which is what I'd kind of been hoping for, that it was my reputation that drew this new patient, not that their insurance had changed. So as a locums physician, yes, I mean, if you go somewhere for a week, there's not going to be a lot of continuity of care. But, if you're an ER doc, there's no continuity of care. If you're a neurohospitalist, there's no continuity of care. Average length of stay is 4.2 days. So, you may have some bounce backs for a variety of reasons. And it is always disturbing. I know that name. Didn't I see you 2 months ago? So, I mean, that's continuity of care. But as a locums doctor, yes, you have less. But I think it's not really a thing anymore, continuity of care. So as a downside, I think that's a very, very tough argument. I think it is more difficult than people realize, because if you remember when you were a medical student and you did rotations, right? Or as an intern, it's like, okay, I'm done with renal. Now I'm going to do cardiology. So you go to a new floor. It's different nurses, different doctor, different way of doing things, different part of the hospital. Well, that takes a little while to adjust to. So as a locums doctor, you're going to a new hospital. Maybe you don't know how to run the EMR, right? The electronic medical record. In fact, I'll just put in a little plug here. If you are doing locums and you get an assignment, one of your first questions should be, hey, by the way, which electronic medical record do you use? Are you using Cerner or Epic or McKesson? And if they give you a name that you don't know, you say, oh, wow, that's great. I'd really love to come a couple days early and get trained on it before I start. And you'll pay me too for those days. And they'll say yes. And because otherwise your first day is going to be a total nightmare, right? And that's happened to me. I wrote about that. And where I'm trying to admit patients from the ER, and nobody in the ER actually knew how to do that because they were ER docs and they never admitted anybody. So what I was trying to do, they actually didn't know how to do. So some tech person had to come from home at 2 a.m. and help me admit patients because I didn't know how to run the EMR. So I didn't make that mistake again. So you have to learn a new EMR. You have to learn where to park. It's a new city. It's new people. You have to be flexible. They may do things a little differently. Maybe they admit everybody the night before for surgery and you've got to go see them, whereas in your hospital, oh, didn't bother with that. And you can't be critical, right? I, I give the example, it's like being a guest in someone else's home. So, Shala, say, you're going to offer me a job and you invite me to your office. And I come to your office and I see that beautiful plant over there. And I say, Shala, that's a wonderful plant. It really should be over there on the other side of your office to kind of complement the furniture. You would think I was totally out of my mind, right? So if you go to the hospital as a locum tenens doctor, you say, at my hospital, we do it this way, and it's much more efficient. That is not going to make friends or get you much traction. So you just got to keep your mouth shut. As long as the patient's life isn't in danger, you don't have to change it and just get your work done. And that's the beauty of it. All you have to do is see patients, write your note, go home. So the hospital politics, the coffee maker doesn't work. This one said that, and that one said this. You don't care. It has nothing to do with you. You're just there to get your work done. And you also appreciate it because, as I said earlier, you're there because there's a catastrophe that has recently happened. Maybe administrative, could be physical. One of the jobs I had, Buddy asked me to work in his place, and what had happened was 3 of their neurologists had departed in the previous week. They were disgruntled and had gotten a better offer literally across the street and gone. And he had a lot of commitments to patients and they had some contracts and things that had to get done. And they really needed me. So when I showed up, it was like, oh, Dr. Wilner, we're so glad you're here. And I thought it was my reputation. Oh, they've heard of me. They know what a great neurologist I am. But that wasn't it at all. It was just that I was a warm body and they were overworked and now I was going to pick up the slack. So they were thrilled. I mean, they didn't care if I had one eye and one arm and, limped across the room and had only been to medical school for a week. The fact that I was there was going to help them. So that's a nice thing about locums is usually people are very appreciative.
We're going to pause here for this week, but don't go too far. We'll be back for part 2 next week and we'll tune into the rest of the conversation. Thank you.